Welcome to Conversations with Kay. I'm Kay Ryder. And every week I talk with Vermonters who are leaders in the fields of government, healthcare, education, the arts, and community life. And welcome to our listeners on radio, WBTV-LP, and 99.3 FM. My guests have long titles today. Judy Peterson is the president and CEO of what was formerly the Visiting Nurse Association of Chittenden and Grand Isle Counties. Todd Paterson is the new director of home health services at the agency. And they have a new name. We're going to talk about that and what they're doing now. And the new name is UVM Health Network, Home Health and Hospice. Now, I may not say that right all the time, but bear with me. Anyway, welcome.
Hi,
nice to have you here. Judy, why has the VNA of Chittenden and Grand Isle Counties changed its name?
Well, I think you know, of course, Kay, and I think many of your viewers and listeners are probably aware that in January, the Visiting Nurses, VNA, affiliated with the UVM Health Network. We did that because we really saw it as assurance for our future and giving home care an opportunity to have a real voice, a stronger voice in the healthcare system overall. The network before that had just been a group of hospitals, so we did affiliate then. So we wanted to have some successes, which we have had, and my friend Todd will explain some of those programs in a few minutes. But we realized that Visiting Nurse Association, VNA, is not really descriptive of who we are now and what we do. The VNA had so many programs, and now as Home Health and Hospice, we're continuing those programs, but it's much more than just visiting nurses.
Yes, you know, for years you've had this great home care staff with social workers and physical therapists and all kinds of people going into homes, and I hear what you're saying. So will this affiliation really provide better care for people?
We really believe it will, and that it is. Otherwise, we would not have made the change. By affiliating, Home Health now has a stronger voice, as I said, within the network, working with the hospitals. We have more seamless communication and transitions for patients when they're in the hospital, for coming home. We're doing projects now where we have our home health nurses going to physician offices. We're doing video conferencing. There are just all kinds of things that are new opportunities for us since we've joined with the network.
Well, I think, is it an exciting time for you?
It is very exciting. You know, Kay, I've been in home care for over 40 years, and I've always myself known the value that home health can bring. And now I feel like more and more people are recognizing that value. All the hospitals, the physician offices, other care providers, they really see that as we're all working together to try to improve health care and decrease the cost, that home health is a really essential partner.
Plus, people want to be at home. I mean, that's the bottom line.
And you heal better at home.
Yeah, people want to be at home.
Yeah.
And the real name of the game, you know, like you said, costs are not as great at home.
Yeah.
And so, Todd, let's talk about what you have here now. You're avoiding unnecessary hospitalizations. Yep. Nobody wants to really go to the hospital unless they have to. And when they have to, that's fine.
Right.
And ER visits. A lot of the driving costs in healthcare, people arrive at the ER, and if they don't need to be there. So let's talk about some of the things that you are doing. And let's start with something that I think is quite exciting. The primary care outfit, the doctors at the Heinsberg Medicine Office. Let's talk about what the VNA is going to do there.
Our nurses refer to that as our embedded nursing program. And so we'll have a nurse from our home health on hand at the practice that'll be able to collaborate and to provide guidance on chronic patients that have chronic conditions and multiple complexities. So
now,
we're
what is a
excited about
chronic
that.
condition? Can you tell our audience what that means?
A long-term condition that impedes their health and wellness, and so that collaboration with the physicians and nurses in the practice that have seen the progress and the process will be able to give better insights into us on the front line, and hopefully we'll give them good information too from the home.
And you know, good examples of those chronic illnesses are things like diabetes, congestive heart failure, emphysema, those conditions that people live with over long periods of time, and they can go through periods of being very stable and everything's fine, but then things can get worse, and that's when they have a hospitalization. So by home health working more closely with the primary care physician, with the doctor, we'll be able to catch that ahead of time and talk to the doctor, get treatment, and avoid the hospitalization.
That's good. I think someone with a chronic problem, they hate this idea of bouncing back and forth.
Oh,
Correct.
exactly.
It's so hard, and I
Right.
think I myself wouldn't want to do that.
Right, exactly. Yep.
Yep. I'm talking with Judy Peterson, who's the president and CEO of the newly named VNA, which is the University of Vermont Health Network, Home Health and Hospice, and with Todd Paterson, who runs Todd runs the home services for this newly named group. Okay. Now, Todd, let's go on to talk about telemedia. What is telemedia? How does it work with home care?
So we're using video and voice visits through a tablet to interact between the healthcare givers and the patient in the home. So that allows different departments. You know, currently we have a project that we're going to be doing with vascular and palliative care, and those physicians will be able to interact in the home with the nurses and the patients and create that bridge of communication.
Okay, so in other words, the equipment's in the home, and the nurse or physical therapist can report back to the VNA office. The patient can also report back.
Yeah, and it's very portable. It almost looks like a little iPad. People know what an iPad is like, or a tablet. And so the nurses can take that into a person's home and facilitate a visit even with a physician. So the doctor in his office or her office will be able to see the patient, see the wound, see whatever it is that the nurse wants to communicate with the doctor. The doctor can talk to the patient, and all through this video information on the iPad.
That's great. It's
Yes.
wonderful.
Oh, it really is.
You know, we often wonder what these little pads, you know, I'll sit and look at them, you know.
Yeah.
We all email, you know.
Right, yeah.
and things like
Right.
that. But, you know, this is marvelous. The technology for this is so helpful.
And especially nowadays when we have a shortage of physicians, a shortage of nurses, that there's sometimes an access problem for people. This allows physicians to be able to see a person. Also, just imagine if there's someone who's home and they're ill, and say they have one of these chronic diseases, or maybe they have some kind of a mobility problem, so they're not able to get out well, they're homebound. We've had patients that sometimes have to use an ambulance transport to get to the physician's office for a visit. That won't be necessary. The home health agency will facilitate that through the video technology, so they can have their visit while they're at home.
Riding in an ambulance is no fun. I've done that.
No. And it's expensive.
Yep, that's right. Now, you mentioned, Todd, that palliative care and vascular surgery, you can particularly follow up on these. Now, these are complicated and complex things. Judy, tell our audience, what is palliative care?
So palliative care is really an approach to care where what we're trying to do is manage symptoms. Just imagine pain, nausea, vomiting, and so palliative care is provided to people who have very serious illnesses.
They may be dying. They may be in the hospice program, right?
Yes. They're not in hospice because they're still treating their disease, but they probably have a very serious diagnosis. They're seriously ill, but they're still treating. Some people are able to be on palliative care, go through their chemotherapy, their radiation, whatever, and with home health and hospice helping manage their symptoms. and helping them be more comfortable, and they're able to, you know, graduate and be much better. Other people do progress to hospice and then have end-of-life care with home health.
Now
and hospice.
I understand that. I mean, I've had breast cancer and I've had chemo, and you know, I understand how valuable it is for that. But vascular surgery. Now tell me, how do you use telemedicine for someone who has vascular surgery? How do you follow up on that?
So generally we're involved for wound monitoring and treatment, and so our ability to be extremely responsive to changes and to communicate that back to the physician or the nurse practitioner, whoever the individual is in the practice, and have an immediate set of eyes to help us make decisions and changes in care is extremely valuable.
Okay, like you might have more pain, patient may have more pain.
They may have a wound on their foot, and the wound may be not healing as quickly as anticipated, and so maybe we need a consult on a change of product for the nurse that's doing the care.
And we call them wounds. People would think of them as like open sores if somebody had an infection. And you can just imagine if a person has diabetes, sometimes they have poor circulation, so they'll get these sores on on open areas that may become infected on their lower extremities, on their legs. So nurses from home health and hospice go in to do dressing changes, apply medications, and unknown to people unless they have this problem, there are a variety of different products and different kinds of bandages and medications and coverings that can be used. And so we have specially trained wound care nurses who are apprised of all that. And so they're the ones who might be doing the visit to the patient, and they need to talk to the surgeon to be able to change some of the orders or show him or her what the progress is.
Well, this avoids, now when I worked at the VNA a while ago, communication problems with the doctors.
Yep.
Some doctors you could get a hold of easily, and others were difficult to get a hold of. And this helps, doesn't it?
Yes, it really does. Yep. I was going to say, we're also doing some video consults, preparing to do these kinds of video consults with palliative care physicians, because sometimes people, when they have a hospitalization, they're introduced to the palliative care service at the medical center. They really have great conversations. They're getting a lot of emotional support also, but then when they go home, they lose contact. They just continue to see their oncologist, continue their treatment. So what we're going to do is facilitate the continued connection with the palliative care group with the video conferencing.
Yeah, well, that's really good.
Yeah.
Yeah, you know, when you have cancer or when you have any disease, it's not nice to feel you have a team.
Right, exactly.
And you know, you're in the hospital and too many people many times coming around.
Yeah.
It feels like too many people coming around the hospital, and then you go home.
Yeah.
And you know, it's a big change. So that's good to do that. I'm talking with Judy Peterson and Todd Patterson. Judy Peterson is the CEO and president of the newly named, UVM Health Network, Home Health and Hospice, and Todd runs the home care services for the organization. Now, we've had a lot of talk in recent years about infusions, doing blood care at home. Excuse me. Can you tell us, our audience, are you going to be doing more of those?
Yeah, we're partnering with UVM Medical Center Clinical Services and Outpatient Pharmacy to provide intravenous infusions to patients in the home. And a lot of those take a long time to provide. It could be hours at a time. So it's much more comfortable to be in the home and receive those than to have to go to a clinic, particularly for people that are working. We even have people that are working that are receiving that service.
Working?
Yes.
Well, that's interesting. Now, how do you handle that?
We schedule with them.
That's marvelous.
Yeah,
that's
it's
marvelous.
A collaborative process.
Yeah, and there are people who have certain diseases where they need regular monthly 4-hour intravenous infusions, and so they're well, they're working, but they need to have this medication administration, and that's that's one of the ways we're doing this.
Great. Well, that's what I like about home care. I've always liked about home care. You go into people's homes and you see them as they are,
and you try to make it as good and as comfortable for them as you can.
Right. We call that being patient-centered, that it really is, and it's looking at the whole person and really trying to fit our services into their lifestyle.
Yeah. And you're noted for your care and your caring. I mean, these go together, don't they?
Yes, that's exactly right.
That's marvelous. So anyway, we have something here, Todd, that you call this typical, healthcare talk, what do you call it here? It's the post-discharge home visit waiver. Now, what do we mean by that?
Well, previously there were people that wouldn't qualify for traditional home health services. And so under a new waiver from the federal government and OneCare Vermont, we're able to go in and provide up to 9 home safety and support visits to some of these individuals.
Okay, now let's talk about this. So if you're on Medicare, you might not be getting covered post-hospital for some visits, which you really need. Is that correct?
Yes, and often it's because the person is deemed not homebound. So Medicare says that for them to pay for traditional home care services, a person needs to be essentially homebound. So that just means that they can't really get out to see their physician, they can't drive a car, they're not out and walking to the mailbox, that they're not bedbound, but that they are staying in their home because of their health condition. What Medicare is now recognizing is that there are some people who maybe they're not homebound, but if they've had a hospitalization, they would still benefit greatly from 1 or 2, maybe 3 visits from a home health nurse to come in, and there are specific things we would really be looking at. And one is the medications that they're on, because there may have been medication changes when they were in the hospital, and sometimes people come home and they're not they're not sure. Do they keep taking the old ones? Are these new ones just a different name for the same thing I've been taking? What's the dosage change? Anybody who's been on a medication like Coumadin knows that the dose may change twice a week. Their medications can be very complicated. So having a nurse, even if you're not homebound, having a nurse come into your home to be able to sit down with you and go through those medications and explain what they do and sort out what you should and shouldn't be taking is really helpful. Also looking at home safety. Are there hazards within the home, whether it's rugs or cords or whatever, and making sure, again, that the person does do their follow-up visit with their doctor. Those are 3 things that are just really essential to preventing another hospitalization.
Well, it sounds to me like Medicare is catching up with the world, right? With the
Well,
world of home care.
Little by little.
A lot more conversations. Yeah.
Yeah, people have been talking for years about unnecessary hospitalizations, keeping people out of the hospital, the cost of the ER visits.
Right.
Finally convinced people that, well, there might be a better way to deal with this.
That's exactly
right. And I think that I think it's long past due that this has happened, and I think that it's wonderful for people who are out there who are ill and in the home. And being homebound, boy, that rule was really stringent when that moved.
Really, exactly. And so that rule still exists. We're just very lucky that here in Vermont, because we have OneCare Vermont, which is our accountable care organization, and they have a federal waiver to allow us to do this. But this is only in Vermont and a very few other places in the nation. I think maybe 10 other places in the nation have this waiver.
Well, Vermont has a history of good home health care.
Yes.
Throughout the state.
Yep.
And led by the VNA in Chittenden and Grand Isle County. I must say that because you have been a pioneer. And I think that it's gradually, bit by bit,
right, by
you being able to provide more in the home and do it well.
Yes.
That this is sort of changing over the years.
And really being part of the UVM Health Network now, again, places that voice for home health services at the table with all of the hospital leaders and the physician leaders. So now together we're talking about how do we improve care.
I'm a great believer, obviously, in communication. And the more you communicate, the more you learn about each other
Right.
and what you can do and what you can't do. I think
Right.
that's very important.
yeah.
So Todd, where did you work before you went to the UVM?
I was the Clinical Operations Area Director for Genesis Rehab Services, and I oversaw 17 programs in the state of Vermont, from north to south.
Okay, just give us an overview of these programs that were there.
Some were services in outpatient clinic, some were assisted living, independent living. Most of the centers were subacute nursing facilities, and even a hospital.
Okay, so you know a lot about home care and about the state.
A lot about the state.
Right, right. And other than the Burlington area and Rutland and Bennington, it's pretty rural.
Yeah.
And that makes a difference when you do home care because people have to go up in the hills in the winter.
Those are the challenges.
Right, absolutely, yeah. And so why did you want to come to work with Judy and her team?
You know, there's been a progression in healthcare, and you know, we understand more now, even than before, how important it is to keep people healthy in the home, and that it's easier to keep someone healthy in the home than get them out of an institution once they've entered it. My background is an occupational therapist, and so you know, looking at how people function in their home environment is really instinctive to me. So I was really excited when I heard the opportunity was available to be part of the team. Right.
Well, that's good. It doesn't do much good to send somebody home after they've had a traumatic automobile accident or something, and suddenly they're supposed to walk upstairs. I mean, that's not going to work, is it?
Well, there's a lot we miss sometimes in an institutional setting. You know, you just don't anticipate the details of the home. So it's really nice to be able to be there and be able to be responsive and keep people safe.
Right, safety. That's very important. That was an important part of the physical therapist's job, right? Absolutely.
Yeah, and occupational and speech too.
Right.
Can't leave any of them out.
We are very, very fortunate to have Todd with us. We're really thrilled that he's here.
Well, that's good to hear. You know, I always, when I interview, I always like to talk to someone who knows about the state. I like that. I mean, that's great.
Yeah.
If you can grab somebody who knows about the state and knows about home care,
Yeah.
that's wonderful. Good for you, Judy.
Yeah.
Good for you. Now, Judy, the former VNA of Chittenden and Grand Isle County in Vermont is the oldest and the largest nonprofit home care and hospice. As you join, as time goes by, and you're in UVM's Health Network, will your community ties remain the same?
They will. In fact, we will only strengthen our community ties. With the support from the network, and again, this opportunity to have a voice at the table, we really see our organization expanding and providing more and better services.
Okay, now let's talk about what won't change, shall we, for just a moment here? You'll continue to provide maternal child health services.
Absolutely, a very critical program. Yep.
That's been part of the VNA ever since you started.
That's right, and when we all begin to look at healthcare reform and how to keep people healthier, it begins at the very beginning. We really need to do that, you know, prenatal and postnatal and family and children support.
The best healthcare dollar is spent right here when somebody's in the tank.
That's exactly right. Yeah.
I mean, it sounds silly, but to have a healthy baby.
That is so true.
Is a very good way to start it all off.
And then to give parents and families the support they need to be able to have good nutrition and good childhood development and understand the value of exercise and the good nutrition and avoid childhood obesity and to avoid childhood adverse events, any kind of tragedy in their young lives. Right. That's how we're going to make healthier adults.
Right, and you know, kids can't vote. Older people like me, with the white hair, we vote, and the kids can't vote. So organizations like yours you need to advocate and support the services for the children.
That's exactly right.
You need the services. You still have a sliding scale.
Absolutely. Yeah, we do a lot of free and subsidized care for our community. We provide our care based on people's need, not on their ability to pay.
Okay, now, but you have talked, Judy, having a voice at the table.
Yes.
A voice for home
yes.
care. You expect that the ideas and the input from home care will be really listened to now more. Will be listened more, yeah?
I not only expect it, I see it happening. Some of the programs that Todd was just describing, those are because we're now getting the support and the cooperation from the hospitals and the physician groups that they see the value of home health. So it's already, it's happening.
Yeah, so all right, so I envision this table of doctors and administrators from the hospital, and you're sitting there,
yep.
and somebody says some kind of a bright idea of what you can, oh, let's go out in the community and do so-and-so. And you can sit there and say, well, we can do this. However, we'll need help and so-and-so, right?
That's exactly right. And you know what's been just really fabulous is I've had many opportunities, and some other leaders from the Home Health Agency have had the opportunity to speak to groups of physicians, hospital boards, hospital administrators, all kinds of people who have believed in the past that they understood what home health services were. And we're blowing people's minds.
Right. Well, that's good. That's
like,
good. I love that.
Oh my gosh, you do that?
Oh yeah,
Right?
big surprise suddenly. Yeah, that's great. As I said, communication.
Yes. Yeah.
Now, we don't have a lot of time left here, but I believe that your agency has recently received special recognition, national recognition.
That's exactly right. I am thrilled to tell you that just last week we were notified that our home health agency has been named among the Homecare elite. And so that's a group of home health agencies who are the top 25% in the nation. And that's for quality, patient satisfaction, innovation, financial management, that were recognized among that top quartile, top 25% in the nation. Really the best of the best, and we're just thrilled.
Well, that's marvelous. It recognizes what the staff does every day.
Exactly.
Todd, right?
That's right.
Yes.
What you're out there doing every day.
They're an amazing group, doing some very, very innovative and brave work in some cases. Yeah. So we're really proud of them.
Truly dedicated people.
Yeah. Brave is a good word.
Yeah.
Because I don't think that people sometimes realize how poignant it must be to walk into a home. You've never really met someone before. And one of your staff told me once, it takes a lot of guts to go and give somebody a bath when you've never seen them before.
Right.
And it does.
Right.
And bravery in the winter. The roads are bad in Vermont.
Yeah.
And but really dedicated.
Yeah. And Kay, we provide services wherever somebody calls home. So that could be, a beautiful home on Shelburne Bay. It could be a very modest home. It could be a tent on the railroad tracks.
Right.
It's wherever that person lives, our staff go.
Well, congratulations on your new name.
Thank you.
I hope I hope that all goes well for you. Stay at the table and keep talking.
Yes.
And thank you for joining me.
Thank you, Kay.
Thank you.
And thank you for joining us on Conversations with Kay.